Welcome to another session of Dental XP webinar. Today's going to be a very interesting one, and one that's been so interesting for me in learning as well. Dr. Dawn Bloor has lectured nationally and internationally and published on the subject of LANAP procedure and the clinical laser applications of the PerioLase. She's a member of OKU, Honorary Dental Society, and graduate with honors at UCLA School of Dentistry. But something that's similar to my family, she's a fourth-generation dentist after her father, her grandfather, great-grandfather, each whom practiced in California's San Fernando Valley. And she's one of 7 professionals in her family so far, so she comes from a great dental family. I'm a general dentist, and Dawn taught me very well. She's one of the best teachers that I've had the pleasure of any hands-on course that I've been to. So she knows her subject. She knows everything because she's been with the company and been with LANAP for the past decade. So it's a pleasure to me to introduce my teacher and our webinar speaker today, Dr. Dawn Bloor.
Thank you, Dr. Goldstein. I really appreciate the opportunity to be with you here today and with everyone else to talk about what to do when good teeth and implants go bad, the standard of care for laser periodontitis treatment. I'm Dr. Dawn Bloor, and we'll be talking about the LANAP protocol and the LAPIP protocol. Today's presentation will review the LANAP protocol, a regenerative periodontitis surgery option. We'll cover what is LANAP. We'll review some LANAP and LAPIP cases, the prevalence of periodontitis, why LANAP works, how it works, how lasers are not all the same, the fact that LANAP is evidence-based. It is the only evidence-based laser periodontitis procedure. Clinical results are guaranteed, and the PerioLase MVP7, although LANAP is the killer app for the PerioLase, there are other things that it is useful for dentists and periodontists alike. This presentation is sponsored by Millennium Dental Technologies, the manufacturer of the PerioLase MVP7, a free-running pulsed Nd:YAG dental laser. In association with the Institute for Advanced Laser Dentistry, or the ILD, the ILD is a nonprofit laser training and educational institution, and I'm proud to say we have achieved ADA CERP and AGD PACE recognition. I work for both of those corporations in the capacity of VP of Operations for MDT, and my most exciting role as the training director for the ILD to train doctors on the LANAP protocol. A little bit more about me. I'm a California native. Home is at the beach, Huntington Beach specifically, and I am a graduate with honors, Omicron Kappa Upsilon, from UCLA School of Dentistry in 1993. The PerioLase MVP7 has been following me around since 2001. I'll say that's a child for me as well and a passion for me, but I also have 3 other children that keep me pretty busy. My AAA team, Ariane, Arden, and baby Austin. Of note, I am also a 4th-generation dentist after my dad, my granddad, and my great-granddad. Actually, there are 7 of us in the family, and counting, I suppose. Generation 5 could be around the corner any moment. Time flies. There's Ariane sitting in the chair next to me. Actually, we posed for this picture, but you know, my staff has for years been telling me, Dr. Bloor, we need to clone you. And well, this is my associate, Dr. Clark at the time. She was with me full-time for many years, and I think I came pretty close to cloning, but I think Ariane will fit right in. And the staff said, yeah, we have to check your shoes when you come in the door and see who we're walking by as we're walking down the hallway. Now I practice here in Cerritos, so I'm close to Millennium Dental Technologies and the Institute for Advanced Laser Dentistry, and I practice with Dr. Greg. Here's our team close at hand, and if we're not seeing patients, then we're training doctors on the LANAP protocol. This is us in Denver. We have 2 training locations. One is in Denver, Colorado, and the other in Cerritos, California, offering training on the LANAP protocol to doctors worldwide at this point. If you don't find us working and treating patients and helping doctors, you'll find us with our family and traveling and out on the soccer field quite a bit. Well, enough about all of me, and back to what I have to talk about, which is LANAP and LAPIP, and how that will help you help your patients. What is LANAP? LANAP is surgery. It is a full-mouth, doctor-dedicated surgical procedure beyond the scope and practice and license of a hygienist. It replaces the blade and suture treatment of moderate to severe adult periodontitis cases 3 and 4 to achieve predictable, reproducible new attachment that is greater or equal to 50% in pocket depths from 6 millimeters to ridiculous in one treatment. LANAP can be used to treat all stages of adult periodontal disease severity from gingivitis to type 1 through 4 periodontitis. It is a patented protocol, and that's for the protection of patients and the validity of research that is being done on the LANAP protocol. The PeriLace MVP7 is the laser that is used to perform the LANAP protocol, and it is the first and only FDA-cleared laser with an outcome claim of cementum-mediated new attachment to the root surface in the absence of long junctional epithelium. And that is a unique claim in the periodontal world, as the outcome claim is typically a long junctional epithelium. This is the PeriLace MVP7. It's actually a wavelength that has been used in the dental profession for quite a long time. This is a 9th generation free-running pulsed Nd:YAG. It's a 6-watt laser. It operates at 20 hertz. There are 7 digital pulse durations, which is very unique, and that is why it's called the MVP7. That's multivariable pulse, of which there are 7. And we have the world's first Android-based color LCD control screen available on this PeriLace, and it has the capacity to do LANAP. It's specifically designed to support the LANAP protocol with all the parameters and the ranges and the safety and the visibility that you would need as a clinician to do the LANAP protocol for all case types and all of your patients with periodontal disease. It actually has a diode mode, or a way to make the PeriLace act like a cutting device, similar to a diode, actually better than a diode in terms of its functionality. The printer allows you to print out the parameters and energy that you use. And probably one of the most unique features on the PeriLace is the ability to verify that what you think you're using, you're actually using, and that is the power meter that will verify that the power output of the device is actually equal to the setting. It's easy to move around. It's only 43 pounds, and it rolls on a cart, so it easily stores all of the goodies that you would otherwise use during LANAP. It comes in multiple colors, and the Android screen is actually mounted now on a ball mount similar to what you're seeing here in this center picture. The white PeriLace unit has this very ergonomic, very easily visible, very user-friendly graphical screen. And unique to the laser industry, the Android graphical user interface is easily upgraded for those such that it's backward compatible, basically making obsolescence obsolete. So those who have already purchased a device don't have to, again, purchase a new device, but just to upgrade their existing device easily so. This is the only laser company that allows you the opportunity to custom paint your lasers. So whatever is your fancy and whatever excites you, you can actually integrate onto your PeriLace laser. I'm also proud to say that the PeriLace is made in the USA, so we've got that flag proudly on this particular slide. Another piece of proprietary equipment is this TrueFlex handpiece, and actually the FiberFlex fiber that goes with this. And this allows the clinician to bend and rebend the cannula such that you can reach anywhere in the patient's mouth, and it is truly a replacement therapy for the blade and suture technique because of that feature. This is the LANAP protocol in a stepped graphic that shows you some of the steps, but not all of the steps actually. The first is a bone sounding, or to identify your defect. The first pass is shown here in this panel, and that is the removal of the diseased epithelium from the inside of the pocket. The root surface is clean and debrided, and access to the depth of the defect is achieved. We have in this panel showing a second pass of the laser energy at different parameters, such that a clot is formed and stem cells that are released from the bone and the PDL are trapped in that. And this is sealing the reedy ridges back to the clean root surface, and then to adjust for any occlusal trauma, which is a very important aspect of the LANAP protocol, is the occlusal adjustment. All of this sets the environment for regeneration of new attachment back to the root surface in the absence of long junctional epithelium, and that's what we have shown with human histology to prove that that is the outcome for the LANAP protocol. So those 7 steps are only part of what is actually 26 very well-defined steps that require didactic and live patient training over 5 days, over a 12-month period, to become a licensed and certified LANAP clinician and to qualify for LANAP proficiency. Training is so important, especially the live patient aspect of it. 3 of the 5 days of training is with live patient treatment, because it is only when you see the effect of the energy on the tissue that you can appreciate what you're doing. And to avoid problems like this, training is required to avoid such type of injury. It is a hands-on training, or hands on your hands specifically, so that you get the feel for how to do LANAP. And this occurs during 3 of the 5 days, like I said. 3 days of training is required up front before the company will even ship you a Periolyse to do the LANAP protocol. And this is an important aspect to understand the functionality of the device, to understand tissue interaction from the laser energy, and to appreciate what you're doing. And for the company to make such a profound guarantee, clinical results are guaranteed based on your training, that's a pretty confident and bold statement to offer to our LANAP customers. LANAP is all about the patient, as the company is very dedicated to the training that goes to all of our customers. And perhaps some of you have seen some of these classic clinical cases. These are some of the earliest patients that were treated with the LANAP protocol by the co-founders, Dr. Robert Gregg and Dr. Delwyn McCarthy, who initially treated some of the most severe cases of periodontal disease as a last-ditch effort for the benefit of the patient who would otherwise have to have those teeth extracted. In this case, for instance, a typically difficult case to treat with conventional methods is a furcation involvement of a maxillary first molar, that with one treatment of LANAP you can see this furcation fill that went from a 10mm pocket to 2 millimeters with no bleeding on probing. And this was after a 14-month time frame where the patient wasn't even in for continuing care. And staying stable over time. This is a 9-year post-op of this particular patient's molar, still stable. Dr. Gregg also has provided this case, and you may have seen it also. This is a tooth that would otherwise be extracted, and it's being evaluated at the level of this green line for bone fill and for bone density over a period of time, 9 and 14 months. And you can see the amount of bone fill, and the graph below is showing how the increases in density is improving over time as this dark area is becoming less and less. But even at 14 months, we can see that there's probably more healing to come. Clinically, this patient went from 9 to 2 millimeter pocket on the distal and 3 millimeter pocket on the mesial. And no, that's not bleeding on probing. That's, I think, bleeding on stabbing, given the level of pressure that's being used with the periodontal probe on this patient. The lingual aspect of this tooth, this is the way the patient presented initially, having lost some of that tissue volume as a result of a mandibular lingual bar on a partial denture. This case is also compliments of Dr. Gregg. This tooth would otherwise be extracted. It was treated one time with LANAP, and you can see the improvement at 1 year post-op. And the aggressive occlusal adjustment, as I pointed out, is a big part of the LANAP protocol. As I described on the steps diagram, you can see even to the point where he's ground away part of that amalgam. Here's the same tooth, 3 years, 5 months post-op, and showing stability over time. Look at the PDL that's starting to form in here and the furcation fill. Very exciting. Now, these are not the exception. These are the norm when treating patients with the LANAP protocol. CT scans have really offered us a unique perspective as to what we're doing with LANAP. Looking at a patient like this, appreciating the lingual and buccal aspects of teeth that we would not otherwise see with conventional radiography, and looking at the before and then the after just over a year later, and appreciating the three-dimensional aspect of the bone fill that we're creating post-LANAP. I'd like now to share some of the early cases that I've treated with the LANAP protocol. First, to share with you that even as a new LANAP clinician, I was getting profound results for my patients, really life-changing results for many who had simply given up on dentistry altogether and were in quite severe situations with their periodontal disease, to the point they were looking at losing teeth in many of these cases, and in others where they wish they could do something aesthetically, but because of their fear for progressing with treatment had not done anything. So here are some of my cases since 2001, a few in particular that are dear to my heart. I'm very excited for the changes that have been made for those particular patients. Perio is paramount. It is multifactorial, and we can only control some of the variables, but the variables that we can control are very predictably done with the Periolase to accomplish the LANAP protocol. In this case, this patient is looking at a serial posterior maxillary extraction of the first and second molar. And 5 years post-treatment, this patient is still stable, and you can see the amount of bone fill not only around this first molar, and yes, this was retreated and a new crown placed, but also the bone fill around the furcation and furcations around this second molar, and that's a unique outcome for treating periodontitis. It is not a unique outcome using the LANAP protocol. You can see that now this patient's moving forward with orthodontic treatment because although she had wished to save teeth, she also wished for them to be straighter, so we're able to move forward into the next phase of treatment for her. We have done and continue to do a lot of combination periodontal disease treatment and orthodontic treatment. This patient has a 12-millimeter pocket wrapped around the distal of this molar and into the furcation area, and you can see 5 years post-op we're moving forward with ortho too, since this patient is now so stable, and we can create not only periodontal health but also get other things that the patient wants accomplished, such as straighter teeth. This patient hadn't seen a dentist for over 35 years, and this is not bone. This is actually calculus on the teeth, and 3 years later you can see the amount of bone fill increase in quantity and quality of the bone over those years. You may not appreciate looking at this patient's radiographs that this is how she presented in the office. This patient is not on any medications, does not have any systemic issues. This is just pure neglect for 35 years. This is immediate post-LANAP, and you can see the red thrombus that's formed, this seal around the neck of the teeth all the way around. And what's noteworthy is that there's no burn, there's no loss of tissue volume, there's no epithelial peel, there's just this nice seal all the way around these teeth. 1 year post-op, after just one treatment with LANAP and nothing else except regular maintenance visits, this patient presents in much greater situation than she was originally. This is 2 years post-LANAP, and as you can see, the tissue continuing to improve over this time frame. This is very consistent with using the LANAP protocol for our patients with periodontitis. And at 3 years, almost the appearance of Kevlar to the tissue. Here's another patient that presented, and I want you to appreciate the very tissue-sparing treatment that we have in the LANAP protocol. As you look at this patient just a month post-op, and although the tissue quality has more to improve, you can see that this is just the beginning phases of healing. You certainly can appreciate that we've done nothing to resect or damage the tissue, that we have not caused any recession but maintained the tissue volume for this patient quite well. Here is another typical periodontal abscess, and I just want you to appreciate that the quality of the tissue following the LANAP treatment. This is 3-year post-op. Here's that Kevlar appearance to the tissue that I was talking about. This is one of the more advanced cases that I said is rather dear to my heart. She came in, you can't necessarily appreciate that tooth number 7 was actually in lingual version, tucked in behind the opposing canine in crossbite. And she also, this tooth was also non-vital. She eventually needed root canal therapy as well. 1 year later post-op, we actually, post-LANAP, moved that tooth into alignment and splinted it there. And once she was periodontally stable, she decided to go forward with orthodontic treatment. Originally, she walked in the door afraid she was going to lose her teeth, and then ended up so happy to save them, and then can move forward with the treatment that she really wanted to have done, which is to get a straighter smile, healthy smile, then straighter smile. Patients like this who think they have no options with not only a straighter smile but a dazzling smile because they have periodontal disease now have an option to treat their disease in a patient-friendly way. Another patient who was in the same circumstance, she had cosmetic concerns but had to overcome the periodontal concerns. And here is her process in the provisional phase, moving from a quite diseased state where she started to a healthy state and a healthy and happy patient with the smile that she's always wanted to have. And it's a big part of treatment for these patients to overcome their fear of moving forward with periodontal disease treatment when we're offering them conventional methods that are scary to them. They don't want to be scraped, they don't want to be cut, but they're happy to accept an alternative. So those patients really, in an area where I was practicing in Sherman Oaks, we didn't see a lot of patients with that severity of periodontal disease, but just getting the word out that there's a patient-friendly alternative really brought them in and out of the woodwork. It's not just Dr. Gregg and Dr. McCarthy, not just me, but really LANAP clinicians across the United States and now worldwide that are getting these types of results. Some you probably know, like Mark Nevins, a periodontist who has been doing LANAP for some time now. This is one of his cases that he's shared with us. This is pre-op and this is 9 months post-op, and you can see the bone fill around these molar teeth and in these furcation areas. Dr. Nevins, obviously, he's a periodontist. This is working in the hands of GPs like myself as well. Many of you probably know who Dr. Kim Cooch is, and this is one of the cases that he has shared with us. And you can see, again, in this furcation area, the amount of bone loss, 10 millimeter pocket, resolving to 2 millimeters over the course of a year. So this is really exciting for LANAP clinicians, but even more so for patients to save teeth that they otherwise thought they were going to lose. Talking about the LAPIP protocol, or laser-assisted periimplantitis procedure, I wanted to share with you some of the successful treatment outcomes that many of our customers have shared with us, not the least of whom is Dr. Marie Salama, as part of Goldstein, Garber, and Salama's team Atlanta, who came to training. Actually, we came to them to train them in their office in October of 2010. And you can see here the hands-on training, all 3 of them here. Ron, there you are. and Maurice and David, and here I am teaching the secret handshake of LANAP, which is our hand on your hand doing the LANAP protocol. And here was the big celebration at the fellowship dinner at the end of the weekend, providing the LANAP proficiency certification. And I've heard this said by the three of them before, that the tissue is the issue, is a quote from David Garber. I'm sure I'm not the only one out there who has heard these comments. And the bone sets the tone, quote from Maurice Salama. And yes, I know, Ron, I think it's the screw is the clue. But in any case, the bone was definitely setting the tone here for Dr. Salama as he's shared this case with us. Here you can see the before x-ray preoperatively. This case would have been an extraction, graft, and new implants placed and restorations to be redone. And what a benefit to the patient that 1 year post-op, this whole restoration and implants are now still in the patient's mouth, and this is a huge service to your patients to be able to offer this to them as opposed to the alternatives. This is not just Maurice getting results like this, but clinicians all over the United States and worldwide, and here are some others that I'd like to share. This is actually compliments of Dr. Neil Learman. He's also an instructor for the IALD, and you can see this pre-op x-ray taken in 2010. 7 months later, you can definitely see the improvement. I may be concerned still that this tooth isn't over the hump yet, but giving some additional time. This is 18 months post-LANAP after just one LANAP treatment, and you can see what a service that he's provided for his patients. This is another lip PIP case by Dr. Kirk Norian, and you can see the before and 15 months post-op and the profound result that he has here. This case actually went from a 12 to a 5 millimeter pocket with no BOP, so it's an astounding result. So how does LANAP and LAPIP compare to traditional periodontal surgery? What are I doing for the treatment of periodontal disease with conventional surgery? A cut and sew method. Here is a patient treated by Dr. Ray Yuckna, and he had done conventional osseous surgery on half of the mouth before he was trained in LANAP and to do LANAP on the other side of the mouth. I wouldn't recommend doing it this way, but if that's what you're faced with, then better to offer it than not. But you can see the amount of resection here that is accomplished during traditional surgery versus LANAP. Now, you may say, well, what were the probing depths and what was the outcome on both sides? And you can see with the befores and the afters and all the red arrows representing some increased pocket depths and the resolution of those pockets over time, both on the LANAP treated side and with traditional osseous surgery. Here is another picture to show the difference between traditional surgery and LANAP. So which is which? I don't think it's hard to figure it out, but definitely LANAP is a tissue-preserving, tissue-sparing therapy as opposed to a resective technique is obvious. And what about LAPIP? This or LAPIP? I don't know what this is, but I want LAPIP, not this. You may be thinking that, but LAPIP, a laser-assisted peri-implantitis procedure, is an option, an alternative to doing this, which is the removal of the failing implants, grafting of the site, waiting for that graft to integrate, and then placement of new restorations. All this is one way to do it. LAPIP offers a patient-friendly alternative. And what does your patient want? That's the question. I don't know if anyone else out there has this experience, but I call this the periodontal abyss. And that is what I used to experience before I offered LANAP and LAPIP, and that is referring my patients to a periodontist, and I get the comment, you're not going to cut me. They say, I don't care what my doctor says, I'm not getting this done, let them just fall out. I'd rather just do that. And really that's what this no cut, no sew, no fear logo is speaking to. It is those patients who have simply given up on dentistry to know that there is a patient-friendly alternative available to them. And my experience is that they come crawling out of the woodwork to be seen and to be treated with the LANAP protocol. Patients like this one who had given up on dentistry for 25 years. 25 years of neglect is what caused this patient to have this level of disease, and she'd given up because she didn't know there was any alternative. This is immediate post-op, and you can see again there is no char, no resection of the tissue, no epithelial peel. It almost looks like nothing was done, and here she is 9 days post-op and with great resolution, beginning of the healing phase for her. LANAP and LAPIP have higher case acceptance, less stress for the patient and the doctor, less pain for the patients, fewer visits, and better aesthetics when everything is said and done. So how does it compare? What are the practice dynamics from GPR to LANAP in an actual office? Here is Dr. Kurt Norian's practice. We looked at one of his LAPIP cases, and you can see over a period of time from 2004 to 2008 the number of quadrants of GPR that were done as opposed to the number of quadrants that were accepted and treated on patients with the LANAP protocol. That's a huge jump in case acceptance. It's also a very prevalent disease that we're treating. If you look at some of the common diseases in the United States adult population compared to cancer, diabetes, heart disease, and gum disease is a disease too pervasive to ignore. In fact, the IALD has done a lot to increase awareness by starting a Fight Gum Disease or a Gum Disease Awareness Month that has been adopted by 7 states so far. It's a disease that is contagious. It's a disease that's linked to several life-threatening health problems like heart disease, stroke, respiratory diseases, diabetes, stillbirths, obesity, infertility, several cancers, even Alzheimer's, and the list continues to grow. And this is something that our patients are really keying in on. Unfortunately, despite the huge number of patients with periodontal disease, there are not many being treated. 3% of the 50% with moderate to severe periodontitis that are informed of it actually seek treatment. So it is a disease begging for a solution, and the LANAP protocol offers a great solution for your patients, something that your patients will accept, and something that provides scientifically proven regenerative type of results. Cementum-mediated new attachment to the root surface in the absence of long junctional epithelium. So this is the protocol that we're talking about and the steps that are involved to treat patients that are in need of our help and to reach all of those patients who have gum disease but are not being treated. Whether it is the prevalent statistics from Michael Newman, who reported it at UCLA at the annual conference on periodontal surgery, that with over 200 million in our adult population, 50% have moderate to severe gum disease and only 3% are being treated each year. And prevalent statistics range depending on who you're looking at. The ADA reports 75%, the U.S. Surgeon General reports 85%. But what is really eye-opening is that the prevalent statistics are being underestimated, or I should say perhaps underreported, that they're underestimated by more than 50%, and severity is actually underestimated by more than 60%. So it is a disease that is profound, and it is in need of being met. So compared to the number of patients seeing a general dentist, for instance, there are very few that actually seek treatment for their gum disease, and given the statistics for prevalence, that's out of alignment. The most common cause for advanced periodontitis is misdiagnosis or lack of diagnosis of early periodontitis, which perhaps speaks in part to why there are so few patients getting treated. Perhaps it's not just the fear factor, but also the lack of diagnosis on the part of the dentist and of hygienists to identify the existence of these defects. Really wanting to emphasize here to everybody that when you're looking at your own patients in your practice, that the disease or the defect actually exists at the depth of the defect underneath the interproximal contact, that you really have to come in at an angle to explore where that's at and not miss it entirely by just probing where the line angle is. So take a closer look at your patients and put a periodontal probe on your bracket table and not just on your hygienist bracket table, and see what you see. It will surprise you most likely. So why does LANAP work? It's basically wound healing 101, and it really goes back to things that Bube, Carranza, and Goldman already knew about, but weren't able to consistently get the results that we're getting with LANAP, but knew why it was going to work. They defined the fundamentals of what's necessary for this type of regenerative healing to take place, and that's to remove the infected tissue. It'd be great to leave the healthy tissue behind, kill the bacteria, remove pathogens, create a clot, and keep it there. And the advantages of the Periolase MVP7 to achieve that environment, specifically with the benefits for selectivity, bacterial kill, and to close the system, are profound. Let's talk about selectivity, removing the disease from the health. In this photograph, you can see the laser energy from the Periolase actually removing the black ink from a business card without burning a hole through it. It is as if the energy can tell the difference between the diseased tissue and the healthy tissue, as it seems to be able to do in this histologic section, showing the removal of the epithelium from the underlying reedy ridges. In fact, this particular histology shows the milestone research that was done and published in 1994 by Drs. Velarde and Gold, showing the ability to remove the epithelium from the subjacent connective tissue without damaging it. In fact, 83% of the histologic sections showed 100% removal of the epithelium. In fact, Dr. Mario Velarde is a LANAP clinician, and the laser that he used to complete that study was actually one that only had one and a short pulse duration, such that he was frustrated with the ability to only get the removal of the diseased epithelium, but not to be able to control blood flow, which is what the Periolase does so very well. So he wheeled that laser device into the corner and really was excited to explore LANAP as an option just this last year. That first pass that you saw is laser troughing. It's accomplished with short pulses, which is the type of laser that Dr. Velarde was working with. Bacterial kill is another advantage for the Periolase, to kill the bacteria and remove the pathogens. This image is showing the laser energy traveling through the air, through the anesthetic, and removing the black ink off of the label on the opposite side of the anesthetic. It really speaks to the power of the energy and having the ability to go some distance, reaching out into the carpule, into the tissues as it does for our patients, and ablating the bacteria that is deep in the tissues and the bone and on the root surface, kind of like the energy reaches into your popcorn bag and pops specifically and selectively the kernels of popcorn inside. And this is the ability to do that based on the pulses that are in the thousands of watts per pulse. At 2,000 watts per pulse, it's very bright and intense at depth. The energy has the ability to reach in to those areas at depth to kill P. gingivalis and destroy the pathogens that reside there. Kind of like you see in this image of this green laser light reflecting, scattering, and absorbed in the T, and having an effect at distance and also away from the area that it's being aimed at. In the periodontal pocket, this is what it would look like, where the laser is inserted into the pocket, but the energy reaches far beyond that, and because it pulses in the thousands of watts per pulse, it's packing a lot of punch so that when it does run into bacteria that may be hiding into the tissue in the root surface and the calculus in the bone, and even if it's not right in front of where the energy is being aimed, it still has the ability to ablate it. It has the ability to reach about 6 millimeters into tissue and actually about half a millimeter into dentin. This is actually not in contact but at some distance, so you can understand the effect of ablating the P. gingivalis, both in the tissue and in the root surface, in the cementum and the dentinal tubules. The last of the advantages I wanted to talk to you about today is the ability to seal the deal, or to close the system. We do that by creating a blood clot and then being able to keep it there, and that acts as a seal or a gasket around the neck of the tooth that prevents epithelial downgrowth and also prevents recontamination of that area with bacteria and debris. This is what it looks like. This is that gelatinous clot that forms by changing the nature of the blood into kind of a blood jello that seals this at the neck of the tooth. It closes the system, or closes the wound. So here is that red thrombus remodeling into this white fibrin, or the first connective tissue attachment back to the root surface, and acting as, well, nature's nectar, your GTR barrier. It's not unlike what I call an upside-down root canal. You know, we don't think twice about getting regeneration at the apex of a root that's endodontically involved. Well, if we clean, disinfect, seal, and, okay, adjust the occlusion too, we expect to get a regenerative result, recreating tissue that was lost as the result of an endodontic infection. So it is, well, LANAP is kind of like doing an upside-down root canal. How does LANAP work? It really boils down to physics, and that's something, no matter how you want to talk about it, what rep would like to say otherwise, you can't change physics. Now, this particular energy reaches deep into the tissues. It is intense like a bullwhip, as selective as you just saw. So it is tissue sparing and really acts like a guided missile, seeking out the disease but sparing the health. We have a unique ability to create hemostasis, to seal the system, all within very safe parameters for the patient. This is all with the Periolase MVP7, which was specifically designed to support the LANAP protocol. There are safe and easy presets that are visible to the clinician. They're verifiable, which we talked about with the power meter, and adjustable so that it can accommodate all genotypes, all case types, all within biologic thresholds so as not to harm the patient. Not all lasers are the same, as you are well aware, and they vary based on their wavelength and where those wavelengths are absorbed, penetration, how the energy gets to the patient, or the emission mode. Is it free running? Is it continuous wave? How much time is the tissue being exposed to the energy, and do you have visibility of the parameters you're using? Do you have the ability to verify the parameters that you're using, and what is the training like on that particular device? Well, let me try to boil it down to a bit of laser nuts and bolts. It comes down to a few easy things to follow, I hope. The first I'd like to address is wavelength, and that is what it determines where the energy is absorbed and where it isn't. I'll divide the dental lasers into two camps, and these are most of the lasers that we are dealing with on a regular basis. There are pigment lasers and water lasers. The pigment lasers are absorbed in melanin and blood, but they're not absorbed in water and hydroxyapatite. Just as opposed to that, water lasers are absorbed in water and hydroxyapatite, but they're not absorbed in melanin and blood. So what does that mean to penetration? Well, based on where these lasers are absorbed, your water lasers are going to have a very shallow penetration. I mean, basically, we're walking water bags. We're mostly water, so the energy is not going to penetrate very deep. Diodes have a very shallow threshold of effect too, in that they're only a surface burn. Diodes are like a hot branding iron. They don't reach deep into the tissue. Even though the pigment lasers include diodes, the effect is occurring not necessarily because of the absorption so much as the burning effect or melting effect that the laser energy has with diodes. As opposed to these shallow penetrating lasers, the free-running pulsed NDA Periolase MVP7 is a very deep penetrating laser, shown in this picture of the laser energy extending into the green tea and having an effect as it reflects and scatters and is absorbed deep into the tea and deep into our tissues. The impact of laser energy varies based on the different lasers that are available. Let's look at the impact of pigment lasers specifically. Diodes are very shallow effect. They're constant low power, and there's no relaxation time. So the summary of that is the impact of basically a bulldozer. It melts anything non-selectively in its path and has a lot of thermal consequence as a result. As opposed to that, the free-running pulsed Nd:YAG Periolase MVP7, because it's pulsing in thousands of watts per pulse, it has the ability to reach deep into the tissue and have an effect. It operates with very short, powerful bursts, kind of like a bullwhip effect. And there are very long relaxation times in between each one of those cracks of the whip, so to speak, to allow the tissue to recover and to not damage the tissue. So in summary, you can't change laser physics. You can't change the physics of how that energy is going to affect the tissue. Erbiums and CO2s, they are non-selective removal of tissue because they're absorbed in water. They're very shallow. They have low kill of periodontal pathogens because they're not absorbed in pigment, and they also don't reach deep into the tissue, and low to no capacity for hemostasis. Diodes, the bulldozer effect, they're very low power, so they're not very intense. They operate primarily by melting the tissue non-selectively, so you cannot remove the diseased epithelium and not damage the underlying reedy ridges. It's not precise. It is a very large thermal footprint, and as a consequence has the risk of higher collateral damage to the tissue. It has less kill of periodontal pathogens, and that's shown in the research by David Harris as compared to free-running pulsed Nd:YAG, because it's only a surface effect. In fact, the free-running pulsed Nd:YAG outdoes bacterial kill compared to diodes by 16 times. So this is a shallow effect and a less effect on the ability to ablate bacteria. It also acts by melting and burning, so any ability to stop blood flow is just at the surface, and it's kind of a creme brulee effect, not really congesting the tissue below the surface. All of this is opposed to the free-running pulsed Nd:YAG, which is the Periolase MVP7, which operates at a very intense, high, powerful bursts in the thousands of watts, and as so has very selective removal of the tissue and a very selective effect only to affect the disease, like guided missiles ablating bacteria and removing the infected tissue very precisely. There's a very tiny thermal footprint when using the Periolase with little to no collateral damage risk. Because the energy can reach deep into the tissues and has an effect at a distance and away from where it's being aimed, it can reach in and not damage the tissue, but to kill the bacteria that reside within the cell walls and inside the dentinal tubules and calculus and bone. It has the unique ability to create hemostasis, and that is to change the nature of the blood so that it creates a deep, durable, sticky clot that then changes to fibrin, or the first connective tissue attachment, back to the root surface. In this environment, it has the capacity for a regenerative outcome, which is cementum-mediated new attachment to the root surface in the absence of long junctional epithelium, and with recent histology showing additional regenerative results with bone fill as well. So you need to pick the right tool, and you need to know what the laser does and what it doesn't do in order to do so. So I don't put a screw in with the hammer, and if I'm going to treat periodontal disease with a laser, I'm going to use the Periolase MVP7 for the LANAP protocol. LANAP is evidence-based. It is the only laser periodontitis protocol with scientific proof. What does it mean to be evidence-based? The ADA reports that evidence-based dentistry is about providing personalized dental care based on the most current scientific knowledge, and is a combination of all three: evidence, clinical expertise, and the patient's needs and preferences. It's only when all three of these are given due consideration that an individual patient care is evidence-based. And what is the best evidence? It is the highest level of evidence available that represents the current best evidence for a specific clinical question. And what does LANAP have in terms of evidence? There is a lot, starting way back in 1998 through 2002, 4 years, 10 published case studies, Dentistry Today, Inspire, Spy, in General Dentistry, and there are other publications by other doctors than Dr. Gregan McCarthy, who did the initial publications at the beginning of this study. Publications by doctors such as Craig Long, Dr. Kimmel's been published in Canadian journals, Dr. McAllister in Compendium. But what about the histology? What's actually happening on a histologic level and not just with the case reports that have been published at those time frames? The first study that was published in the International Journal of Periodontics and Restorative Dentistry. It was published by Dr. Ray Yukna, who did a histology study on 6 patients, 12 teeth total, so there's 2 teeth per patient. One is a control tooth and the other was treated with LANAP. And the teeth were removed after only 3 months. They were removed en bloc, and all 6 of the LANAP treated specimens showed cementum-mediated new attachment to the root surface in the absence of long junctional epithelium. These are some of the histologic samples to share. This was the control tooth, and you can see this squirt of long junctional epithelium all the way down and into the notch. The notch was placed at the apical extent of the calculus on the root surface, and that was consistent with all of the control teeth, as opposed to the teeth treated with LANAP shows cementum-mediated new attachment instead of long junctional epithelium. And you can see here the old cementum notch. Here's the new cementum, and you can see that very distinguished between the new and the old. And then you have the bone here. On higher magnification, you can see the bone, you can see the notch, old cementum, new cementum, and the PDL between the two. So LANAP is showing a regenerative outcome in this case. Now this is an outcome claim that was unique and was new at the time that it was done. This was the very first time that a laser was used for an outcome claim of cementum-mediated new attachment to the root surface. And so the FDA put the specimens, the histologic specimens, through incredible scrutiny, and these specimens were verified by the FDA and shown not only to achieve this type of attachment, but specifically that there were Sharpey's fibers, and those Sharpey's fibers functionally oriented as opposed to circumferential orientation of the attachment. They also wanted to see that there was proof of no damage to the root surface or to the pulp. The second human histology study was completed by Dr. Mark Nevins, and the histopathology was done courtesy of Dr. Peter Schupak. And this was reported at the AAP this past year in 2011. Actually, it's still yet to be published. In this study, both single and multi-rooted teeth were treated. There were 12 total, 8 single-rooted, 4 multi-rooted, and there were an additional 6 teeth that were notched, immediately flapped, photographed, removed, then SEM'd for proof of placement of the notch at the apical extent of the diseased calculus. And actually that showed that there was calculus extending even beyond the notch placement. 9 months went by as opposed to 3 with Dr. Yukna's study, and then those teeth were all removed en bloc. There were no control teeth in this study because there were control teeth for Dr. Yukna's study, so that wasn't really necessary. All 12 of the teeth that Dr. Nevins treated were considered hopeless, and all of them returned to clinical, radiological, and histological health. Histologically, 10 teeth showed regeneration up to the bottom of the notch, 5 teeth showing regeneration in and above the notch, and 6 showing cementum, and the 6th tooth, rather, showed cementum-mediated new attachment. This is one of the sections that Dr. Nevins and Dr. Schupak has allowed us to share with you, in addition to this one, where you can really see the Sharpey's fibers embedded into the cementum and not just resting on top. The full analysis of the clinical and radiographical and histologic findings are expected to be published hopefully this year in a peer-reviewed journal, and so you can get it straight from the publications, publications, the final results of this study. We have a clinical study that is ongoing. It is a multi-centered study, 3 universities and 2 private practices, the University of Colorado, Louisville, and Maryland. The 2 private practices and the universities have a total of 6 principal investigators that are actually performing the treatment. This 5-site, multi-centered, university-based study is randomized, prospective, blinded, longitudinal, calibrated clinical trial. It's a split-mouth design, 4 quadrants, comparing Lanapt to scaling and root planing and modified Widman over 12 months. Actually, the 4th quadrant is gross debridement. And here we are at one of the site initiations. This is Dr. Yuckna and Dr. Reynolds, 2 of the university PIs. This is our independent study monitor. Dr. Yuckna and I were there to oversee the first patient treated and the study patient and the practice patient at each of the sites as we initiated each one. And here's the randomization envelope if you've never seen one. This is Dr. Henry Greenwell, who's at the University of Louisville and participating in the study as well. Dr. Yuckna's role as a monitor of the modified Widman and actually scaling and root planing procedures during the practice patient to verify that things are being done according to the study design. And I was there looking over the shoulder of the PIs during the practice patients only to look to see that the Lanapt procedure was being performed correctly. In addition to that ongoing study, which will conclude after those patients have been followed for a year post-treatment, in addition to those, Dr. Yuckna has accumulated data randomly from 22 patients, half of whom were treated by him and half who were treated for the very first time by patients doing, or excuse me, clinicians doing Lanapt during their training at the Denver boot camp. And what is fabulous to report is that of the over 3,500 sites and the range of pocket depths that were well past 10 millimeters in some cases, but certainly severe periodontal disease, that almost 94%, 93.5% of those pockets returned to 3 millimeters or less, and only 6.6% were in the range of 4 to 6 millimeters after 1 year of Lanapt treatment, and there were 0 that were 7 to 9 millimeters or greater than 10. So it goes to show you that even the newbie is going to have some profound effects for their patients. Of immediate announcement is this publication by Dr. Lloyd Tilt. He is the first periodontist to start doing Lanapt, and his long-term results are published just this month in General Dentistry, showing tooth survival over time, or the effectiveness of Lanapt over time as measured by tooth loss. And looking at some of the tables, what's most impressive, as Dr. Tilt compared his results to other literature, other milestone literature by Drs. Wood, McFall, and McLeod, that his results stand up very well. Actually, by the way, Dr. Wood is now a Lanapt clinician as well. But if you look at the number of teeth lost per patient, although these patients were followed for less time frame, 6 years as opposed to upwards of 12 to 19 years, that 0.4 number of teeth lost per patient as opposed to 1.8 to 2.6. And also of note is the percentage of downhill patients being only 4.7% as opposed to, well, that's about 75 to 90% less than, depending on which of these percentages you compare it to, than 14 to 23% as seen in the other 3 comparisons. And research continues to be done. There is some research beginning to shine light, so to speak, on some of the possible mechanisms for the pulsed Nd:YAG wavelength and how that is affecting upregulation of BMP2, and how that may be part of the answer that we're looking for as to why Lanapt works so well and how it does. So my question to you is perhaps, How much is enough? Certainly in the discussion of evidence-based, there is a lot of it. And looking by comparison with one tooth was enough for GTR and how many were enough for implants, perhaps it's a question to you, how much is enough for LANAP? Because lasers and perio in the 21st century, and especially the Periolase MVP7 for the LANAP protocol, is here to stay. So I'm wondering, what century are you practicing in? Hopefully it's the practice of LANAP with the Periolase and understanding how lasers have a profound effect for the health of your patients. Dr. Ed Zinman, who is a plaintiff's attorney and a periodontist, has mentioned that LANAP is its own standard of care. It also is part of the standard of care conversation for treatment of periodontal disease, that it is one of the options that a reasonably careful dentist would recommend to a patient who has periodontitis. And many periodontists are agreeing, as we've noticed that year over year the percentage of periodontists coming into the LANAP community is increasing. In 2011, 76% of the new LANAP clinicians were periodontists. So looking at the Rogers adoption curve and what that means in terms of adoption into the profession as a whole, we now have 14% of the active AAP as practicing LANAP clinicians. And looking at this curve, it seems that with opinion leaders and early adopters that we're well on our way to adoption in the profession. So you may wonder, what else does the Periolase MVP7 do? Although the LANAP protocol would be the only reason I would purchase the Periolase MVP7 because it cost justifies the procedure, it is the killer application for the device. There's nothing else that does it and does it like this is done with the scientific proof. What else can I do with it? Because like I said at the very beginning of the presentation, the Periolase is like another one of my children. It follows me around all day from operatory to operatory. What does it do? Well, it creates smiles, like in this case, doing some gingivectomy for a patient with veneers who felt she has too gummy of a smile, and we redid her veneers and did a gingivectomy for her. So there are some profound things that you can do above and beyond the LANAP procedure. Hemostasis effect, crown troughing, gingivectomy we talked about, frenectomy, implant recovery, biopsies, treatment of hemangiomas, really in a unique way, poaching the blood versus cutting, and having a profound life-changing effect for patients who sometimes have some very difficult areas to treat. Using it in conjunction with the treatment of root canals for disinfection, locating calcified canals, removing cement, removing gutta percha. As a general dentist, I found a world of use for the Periolase outside of just treating periodontal disease. Laser pocket disinfection, treatment of herpetic lesions and aphthous ulcers. How many times have your patients walked in the door and perhaps didn't want to have anything done that day because those things were uncomfortable for them? Biostimulation benefits, especially as a dentist with regards to TMJ application, desensitizing teeth. It whitens teeth too, but that's just one of the benefits that you have with the Periolase. So overall, the tide is changing for the treatment of periodontitis with the Periolase for the LANAP protocol. All I can say is I hope you don't miss the boat and don't get left behind, because we are creating incredible benefits for our patient with this technology.
Excellent presentation, Dawn, and I just have a few questions that I think our viewers would like to hear. The first one is, how much training is involved to provide LANAP for our patients?
That's a great question. The training that the ILD provides is 5 days over the course of 12 months. Initially, there are 3 days of training. That happened on a Thursday, Friday, Saturday, and that includes 2 live patient days. Actually, I misspoke earlier in the webinar. There are actually 4 of the 5 days have live patient training. After those 3 days, the laser is shipped to the doctor, and the doctor uses it for LANAP for 6 months, and then the doctor returns for a 4th day of training, and then 6 months after that returns for a 5th day, each time adding different parameters and tools to the LANAP armamentarium so that the doctor is proficient, efficient, and can deal with all case types that are presented to him or her.
So we've got our 5th day coming up in, what is it, December, I think.
I think you're coming out in November, actually.
And it's a month before. And tell me the cost. I forgot what it costs for the whole training.
Well, the entire cost of the training is what amounts to, typically on a lease payment, 1.5 quadrants of LANAP. So immediately the doctor is revenue positive because the rest of the treatment for the patient, being a full mouth treatment, is profit.
And is it covered by insurance?
That question gets asked a lot, and absolutely it's covered by insurance. It is a surgical procedure, as I described during the webinar, and the insurance company and the code, the ADA code, doesn't describe how much modification of the bone is done, in which direction it's done, and what tool is being used. Simply that the requirements in the descriptor are met is the requirement of how to bill and what ADA code to use.
Is there one code, or are there many codes that can be used?
There are different codes depending on what the clinician accomplished, but osseous surgery codes, all of those would be appropriate depending on what's done during the procedure.
Okay, well, I've got one more question, and that's one that you may or may not like, but have you had any failures? Nothing's 100%, I know, but if you have, what were they?
That's a great question, because true enough, it's hard to do everything perfect every time. However, I haven't done anything in my practice with LANAP that hasn't been a good outcome for my patient. And that's the good news, that the worst LANAP outcome that I've ever had for my patient would be a typical good outcome with conventional periodontal treatment methods, including scaling and root planing or osseous surgery. We see pockets reduced by about 50%, every pocket, every patient, every time on average. And all I can say is that the patients get better and they don't get worse.
I see. Okay, well, you've answered my questions, and I think it's time to take some of the questions that our viewers may have. Dawn, it's been a pleasure to have you here today. I always learn from you, and I learned today. Questions were good, and we're just pleased you're with us, and we look forward to hearing more, especially about the research and the new advances that are going to come from the LANAP procedure. Thank you again for being with us, and thank you all for being with us for a dental webinar from Dental XP. Until next time, I'm Dr. Ronald Goldstein.